All right. Should be all set to take over.
Great, thank you. Well, so far it's been a really great set of speakers. I'm excited to join in. A little bit about me. My name is Heather Scott Meyer. I've been a nurse practitioner, board certified since 2013. And I started out in cardiology, electrophysiology, moving my way through the acute care um, areas in both ambulatory as well for UCSF, Stanford, and Sutter. And since 2020, I was also simultaneously working in obesity medicine. I've helped to run several clinics here in the Bay Area, as well as carrying my own large patient telehealth panel. So, needless to say, I've had a lot of experience dealing with some of the more complicated situations that patients present with. So today, part of what I'll be talking about are managing side effects, plateaus, and the concept of helping patient retention, because it really can affect and impact your bottom line. When I started in medical weight loss back in 2020, it was the early days. It was liraglutide, Saxenda. Things were just sort of opening up for the off-label use of semaglutide, and I don't even think Wegovy had been quite approved when I started. So it's really exciting to see how far we've come, especially on the horizon with the polyagonists. I mean, we're looking at now having near bariatric surgery results coming up with retatrutide. I think somebody actually in the group chat had a question about retatrutide. Given that it's still in phase 3 clinical trials, I was just reading yesterday that they're looking at maybe a late 2026, early 2027 release on that. So I know some people are actually able to have that compounded through certain pharmacies. But for the purpose of this discussion, we're going to be talking about the current ones on the market, and I'm just going to call them GLP-1. So this is going to encompass the compounded versions as well as single and dual agonists, just to make it easier to say. So the challenge really that we've seen is the demand is high. So patients are coming to you, they want to be on these medicines, they know what it can do for them. However, in the first year, there's an estimated loss of about 50 to 75% of patients who stop taking GLP-1 therapy and fall off for all reasons. And then of that set, there's about 15 to 28% that stop due to side effects. The biggest issue here is that patients come in with their own preconceptions, misconceptions. There's a wild variety of information available on all the social media platforms. Some is reputable, some is not. People have a hard time discerning that if you're not in healthcare and medicine. So those patients will stop taking the medicine. And as we know, obesity is a chronic relapsing condition. It needs to be treated similarly to hypertension, high cholesterol, or diabetes. So it's been great to see the transition of the mindset changing from it being what you eat or what you're doing for exercise as the only option for treatment. There are studies that do show, obviously, and we know this, patients who feel supported, who have close relationships with their provider, who have education and are empowered with the tools to be able to know how to and react to certain side effects and how to address them, report improved satisfaction rates. So the biggest thing that I have found in my practice is when patients come in, they've had a lot of either anecdotal or personal family, friend experience with people telling them what their experience was, how much weight they lost, how quickly, and then they'll have sometimes, unrealistic expectations of how much weight they want to lose in a very short period of time. So I think the first thing that I found really helps is to review with the patient how the medicines work, because the mechanism of action is actually why the side effects occur. The same reason the thing that we're looking for success has impacts, right? We can't get out of this with nothing. But typically, those initial GI side effects, I'm going to skip to the slide for a second. The GI side effects peak at the first usually month to 2 months for patients, and then will go up and down as you're escalating therapy. Nausea and vomiting being common initially, and then that sort of tapers off, whereas constipation can work its way up and peak later on. So when I have patients come in, we talk about all of the things that you've heard from Dr. Well. We've talked about all of the impacts that endogenous or our own GLP-1 production has. Obviously, we want these medicines to help blunt our appetite, to help blunt hunger and the food noise. But by way of delaying the gastric emptying, that can lead to fullness, bloating, limited appetite, nausea, GERD. So one of the biggest things that I like to talk about is making sure patients start out on the right track, which is hydration. Find out how much they're drinking and set the standard that when you wake up, you should have something and be drinking this, my goal is 80 to 100 for most patients, unless they have a fluid restriction for some reason. Nausea and vomiting are the biggest issues, at least have been in my practice, where patients usually wait till it's the last minute to tell you when it's a severe something that's happening on a Friday at 3. And you have to sit down through, look at their diet recall, ask them what they've been eating, how much quantity are they eating, and the timing of it. Often patients will forget that now we have to also change the diet. Their old normal is not the new normal. Eating on a GLP-1, living on a GLP-1 requires a different strategy. Avoiding the trigger foods like greasy, fatty, fried foods, anything with sauces. Some patients can't drink coffee. Dr. Kaplan mentioned how with the alcohol abuse disorder perspective, it actually helps you to not want to drink alcohol. But if you're still drinking alcohol and you're eating the way you did prior to therapy, you're going to feel horrible. I've had patients who ate a whole pizza and then asked me, they're very confused why this made a difference. I'm sure you all have experiences like this as well. The other thing I like to recommend is breaking up when you drink fluids and not doing it at the same time that you're eating. Your appetite has lessened. You have satiety before you're even really full of food, which means if you're drinking a lot of water during the meal or any, it can help to lead to those symptoms of like acid reflux or nausea. The other thing I sometimes will do is if patients are finding that the nausea is severe on the day of their injection, that they consider pushing it to the evening. That can actually help because obviously if you're asleep and you're laying flat, you're likely not going to be feeling those initial symptoms as much as if you're up and moving around and running to work. I try to get people on a really good plan so that they're not afraid of having nausea, that they know that we have a lot of really great ways to alleviate it. Everything from ginger, B6, B12, over-the-counter medicines. And there's the last step, Zofran, because obviously it is a prescription. There are potential interactions with other drugs to evaluate if that's accurate if that's appropriate for the patient. I also let them know that obviously if you're requiring Zofran every day and you're not able to keep down fluids, you're not able to eat adequately, and we are not able to increase the dose while you're on the Zofran. We want you tolerating the medicine well without side effects or minimal side effects that are not impacting quality of life. So I really like to start off and let people know because they'll ask me, can I have a Zofran before to prevent? I think that's not the right approach because we want you to be able to be on these medicines long-term and tolerate them. If you're giving preventative antiemetics, you're going to run into a situation where you don't know if the patient's tolerating it, and it's not meant to be utilized that way. So the other one, and I would like to say that today I'm only going over a handful of the side effects. There are so many, and honestly, I feel like this could be a multi-module course in of itself. So I'm just picking some of the top ones. So if I'm not discussing something, please feel free to write in the chat, and we'll definitely be talking about it at some point. Let's see. So constipation action plan. I feel like the best method here is actually prevention. When people start the GLP-1, I like to find out what is their typical current pattern. Your current pattern will not be the pattern going forward. These seriously will create constipation pretty quickly. It's a combination of obviously less food intake. You have less in the stomach to be exiting. You're going to be taking in less bulk because your appetite's smaller. And then oftentimes when people aren't hungry, they're not actually focused on drinking water. So it's kind of this new effort of, whereas before people were having an issue with overeating, sometimes now it's the exact opposite. So focusing on hydration, fiber intake, whether this is in a shake form, mixing in the spinach or high fiber greens and protein powder in the morning, but eating something will help immediately to reduce that nausea that people can have in the early morning. I also recommend that everybody is on a fiber supplement for going forward, because it's going to be difficult to take in the amount of fiber that for the amount of bulk that you can handle. Magnesium can also help, usually mag citrate, but I don't really recommend that. Like a normal magnesium supplement is fine. And then if you're finding you've gone more than 2 days without a bowel movement, your patients are not having a bowel movement for 2 or more days, they really need to be on nightly senna and Colace. It says as needed purine here on this slide, but I actually recommend it like 2 to 3 times a week. It will help keep people on track. Miralax and enemas obviously are kind of the big guns, if you will, but it is important. I've had patients come to me where they haven't had a bowel movement in 7 to 10 days. So, I mean, yikes, right? And the issue is this woman then went into the emergency room and actually had to be, for those of you that aren't clinical, I'm sorry, but she had to be manually disimpacted. So the risk is obviously, we don't want people to have a bowel obstruction or have a severe adverse event occur because they didn't handle the constipation. Obviously, walking and movement is something I put up there as a top priority. Walking daily, if the patient can do that, obviously, if they have limitations, they have to do and modify. Doing a sit schedule where you try to sort of train yourself to go to the bathroom and, using a normal amount of time. Don't sit and scroll for 3 hours, but for a few minutes after your meal is done, go and try. As well as the I Love You massage, which is a way to just help stimulate motility. Let's see. So the next slide talks about the other big ones, diarrhea, GERD, and dehydration, sort of not in any specific order. It's interesting that, some patients can really have a hard time with diarrhea. I think it's, in my experience, has been really related to individual. It's much less from what I have seen than constipation, but in the literature and the studies show, there's usually about a 19% rate of reported diarrhea, like for instance, on tirzepatide. Watching sugar-free products, looking at what they're eating, obviously if it's spicy or a food that can be triggering to those symptoms we talked about, it can also trigger diarrhea. Usually it resolves and these things sort of settle down after the first month. If you're finding that a patient still is having anything that's frequent, like frequent constipation, diarrhea, nausea, GERD, any of this, you need to work with them to get it under control. And I would not escalate dosing until you get this sort of all settled. You can do Imodium. I usually tell patients to use that very judiciously because obviously the other side of that coin is then constipation. And then after diarrhea is resolved, probiotics and, those like to help with a healthy gut flora are really important. Hand in hand with the way that the gastric emptying is slowed, it can, in the feeling of fullness, it's very easy for patients to experience acid reflux or GERD. So when patients are coming into my practice, I always am sure to ask if they've had a history of these symptoms, if they're currently on any prescription medication to help control it, because it's very potential that if they do have a history of Barrett's esophagus or hernia, hiatal hernia or GERD, depending on their current frequency and severity of symptoms, they will probably experience an increase. And it's just helpful to help frame that for them so that they're not surprised when it happens. And I think oftentimes patients will abruptly stop taking or fall off follow-up if they're not given the information about what to expect. I think just more education and more preparation for the patient is the best thing to do. Again, similar ways to sort of treat this holistically without medicine. The trigger foods, avoiding eating too close to bedtime, tight-fitting clothes, drinking more water, avoiding the acidic foods, and sometimes even coffee, unfortunately. We all love coffee, but it can be really hard on the stomach, especially if you're on a GLP-1. It can sometimes just be something you should avoid. And alcohol. Alcohol is a big one. Obviously, for patients coming in new onto a GLP-1, it's really important to find out their alcohol intake baseline. And then we obviously recommend reducing it because of the concurrent risk of potentially severe side effects. Another very common issue people experience along with GERD and acid reflux is just this feeling of bloating, belching, or gas. And it's just because of the way the medicine works on the stomach. It can be partially too because of food intake. Gas sacs, over-the-counter medicines can help with that. Avoiding large quantities of gas-producing foods like beans, some really, cruciferous vegetables can do that. Increasing activity. I think it's a great idea for all of us to get in the habit of after we eat a meal of any sort to then walk it off, right? Eating those smaller meals spaced frequently throughout the day, and it may not even be a meal. The new meal may be this big as opposed to previously what they were eating. And then dehydration, when we have patients come on, I'm always looking at all their labs and making sure we know what their kidney function is like, what is their baseline, ask them about their past history. Are they somebody that has a tendency to become, to have upset stomach more than, somebody else? Do they have issues with dehydration? Have they had any past problems? Are they on a fluid restriction? Do they have medicines where they, you need to really closely monitor them? I found that really vomiting is less common in my practice, and I'm not sure what you guys all think. I'd love to hear that in the chat. Vomiting really requires further evaluation. Obviously, when you're dealing with telehealth, we do this via chat or, on the phone or video call. It usually, in my experience, is directly related to something they ate. It can be that you waited all day and realized you didn't eat anything, and that buildup of gastric secretions can be really irritating to the stomach. That can cause vomiting. It could be that you ate a huge meal and tried to eat your old amount of food and found out the hard way that it's not possible. However, if the person is having new onset abdominal pain with nausea, vomiting that's not helped with any medicines like over the counter or Zofran, or if there are any signs of dehydration or fever, of course, they really need to be seen and evaluated either in urgent care or in person. They may need IV rehydration, labs, and possible imaging. In the 6 years that I have been managing obesity and medical weight loss, I've had one patient in that time, anecdotally, that had severe abdominal pain who I sent to the emergency room. She was in Southern California, and she ended up actually having a kidney stone. So unrelated to the medicine that we prescribed, but also sometimes you have no way of knowing. They need further in-person evaluation. Okay, so, I think we've all seen the updated plate method. This is a take on that. And the colors, bear with me, this is actually supposed to be a chicken breast. I could have made that a quiz, but I wasn't going to be mean. So as far as the medicine goes, I really like to sit with patients and find out what they've been eating. And sometimes it's difficult. I feel like patients are sometimes feeling like shamed or shameful or embarrassed about the quantity or types of food. And this isn't about making people feel bad about what they're eating. It's about how do you meet them and how do you provide guidance that can realistically be implemented. Because if we're out over here preaching you should eat all these things, and that's not what they have accessibility to for any number of reasons, or it's just not what they prefer, you have to really look at that and help work with the patient, or it's not going to work. We know that lifestyle interventions are a cornerstone of obesity management and medical weight loss and success, but we can't do it just with the diet, right? We know for a long time the idea had been eat less, work out more. Well, that didn't work. You know, we have an obesity epidemic, and finally we're looking at it from an entire perspective that takes all of those parts and puts them together. So, 50% non-starchy vegetables, protein, preferably lean protein, whole grains to help with providing fiber. Initially when patients are getting used to eating on a GLP-1, I'm like, it's more important that you're getting the calories and the protein in the way that you can tolerate it. Sometimes that means doing, making a smoothie that's healthy at home. Sometimes it's not being that you can eat a specific meal, it's just too heavy. But skipping meals is definitely going to come back and haunt you later on. You'll feel terrible. And the idea is too that we don't want the medicines to completely eliminate the appetite. I think one of the biggest misconceptions I've faced in my practice is patients actually being upset and saying, hey, I get hungry occasionally. Like, well, biological response, like this is how we stay alive. Our body has a drive and we need to still feed it. We want there to be, adequate protein, adequate macronutrients in a person's diet. We don't want it to fully eliminate hunger. Obviously, food noise and bringing down that drive for eating without purpose is really important. But if somebody has a complete loss of appetite, they should not be having their dose escalated. You need to at least make sure that they're getting appropriate amount of caloric intake and protein, because this is when you can have other side effects, which we'll talk about in the few minutes here. As far as nutrition, if you're not or you don't have access to nutrition or RD in your practice, I think it's really helpful to build a protocol in place that you can easily share with your patients. So it can reset how they think about food. They have to change the relationship and their thought process surrounding how they eat, because most of the time they're coming to you and this hasn't been working and they've had an unhealthy relationship with food. So if we ignore that, they're not going to have long-term success, whether or not they stay on the medicines. At some point, it will come back. So this is also a simplified model of the brain, not meant to be exact. So if there's anything not exactly right, bear with me here. But the brain, it's really interesting how this all works with the GLP-1s. Obviously, there are some incidents of mood changes when people are on higher doses of tirzepatide. We'll talk about that in a little bit. They do interact with some of the receptors in the brain, and they help to decrease the appetite, right? We have found that that is one of the biggest benefits of this for people who have this constant little voice in their head that's telling them to eat more. This actually goes away. And by way of that, because that's how the GLP-1s work, the risk is sometimes patients actually have sort of a blunting, if you will, a reduction in just how they emotionally feel. So at the beginning of intake, I always like to get a baseline PHQ-9, assess if they've ever had any history of obviously suicidal thoughts or behaviors. That kind of changes things. You need to look into that a little bit more. Or if they have severe, moderate to severe untreated depression, I would want them to get on treatment while then initiating therapy. it's not a true contraindication to start, but, you know, because there can be an increase in depression, you do not want them to just be left out there. I've only seen 1 or 2 cases in my practice where somebody actually had true worsening depression, and we switched her from multiple agents. And unfortunately, she was not able to continue therapy, but I think that's the only person I've ever seen that happen with. And it was very dramatic. I think that's unusual, but it is really good to have you know, frank conversations with your patients to make sure that they know that this is, although unlikely, but a possible side effect. You know, some of the populations at higher risk for the psychiatric side effects are women, young adults, history of mood or eating disorders. You know, I like to also ask patients if they've had an eating disorder in the past, because sometimes this can be a red flag of disordered eating pattern with a GLP-1. I always want them to make sure they have a good relationship with a mental health professional, because you don't want this to cause any sort of relapse or worsening of that baseline history. Patients not eating enough calories can actually just feel terrible by way of not having enough energy. So before you start considering that this is true anhedonia or depression, you know, look at their diet recall, find out how much protein they're eating, supplement, you know, B12, vitamin D, electrolytes, making sure they're getting enough movement, and making sure they're actually just eating enough and not limiting their calorie intake too much. So beyond the scale, you know, I know Bradley talked about this in depth earlier, and I'm just going to sort of touch on it briefly. You know, it's really interesting. Previous studies had talked about how they felt they showed there's a pretty significant amount of lean body mass reduction when people are losing weight. You know, lean body mass also takes into account liver fat and other contents. So truly measuring it can be a little tricky. Just this March, there was a study published that indicated GLP-1 meds, both semaglutide and tirzepatide, does not actually cause a disproportionate or pathologically significant muscle loss, but rather improve body composition by primarily reducing fat mass. While absolute muscle mass may decrease slightly, the ratio of lean muscle to total body weight improves. So there's always going to be this risk or threat of sarcopenia, or, you know, basically the wasting of muscle. I think setting in a good dietary plan, making sure they're doing resistance training, which really truly looks now to be the biggest factor. Protein's great, but if you're not lifting weights of any sort or using those muscles, you're not going to, you know, retain or build muscle. Rapid weight loss is also more likely to be a factor in losing more lean mass. So, you know, the targets, everybody's a little different. I like to sit down it should really be about their weight, obviously, what their starting weight is, and their goal. So I think doing the macros is very helpful for patients. Not everybody wants to track, and you shouldn't have to necessarily on a GLP-1, but just doing that for the sake of knowing their goal protein intake. Like I said, progressive resistance training, and really following the metrics, like at intake, making sure you do all of your measurements, get a body composition baseline with InBody or something similar. You know, review what the skeletal muscle mass, what the visceral fat percentages are, and really seeing where that nice D curve on the InBody graph is now, so that we can continue to follow that at routine intervals. Getting the arm, chest, hip, and waist measurements, obviously vital signs, labs, and then really looking at goals outside of the scale number. You know, I think that one of the biggest benefits of these medications is that people can go about their life and successfully do things they couldn't before. I've had, I had a woman who wanted to visit her grandchildren, but she felt so embarrassed to go on a plane because she was so morbidly obese that she hadn't seen them in many years. So, she was missing out on their life, and she was finally able to reach enough of a level of weight loss that she felt comfortable traveling and flying. So when we get people started on the medicine, I think it's really important to shift focus from just a weight number, because at some point you're not going to see a big jump in weight as you're getting up to this 12 to sometimes 16-month mark. We'll talk about that more. This way, when you've already established the baseline and you do this at routine intervals and you really empower them with the knowledge of what to look at, they will be less likely to become sad that they're not losing weight. I've had people who are like, well, my friend lost 100 pounds in XYZ date, and they expect to do the same thing. And sometimes that's not what's right for them. See, so this next slide, we're only going to talk about lab values briefly because this is an entirely separate course. But just reviewing and knowing your hard stops or things that will require further discussion, pancreatitis risk, high triglycerides, we really need to look at that prior to getting them started. There's really no specific hard stop on a creatinine level limiting people from coming on. However, in my telehealth practice, we had a protocol where if somebody was a stage 3, 3A, 3B, we really wanted them to have a serious conversation with their primary care doctor to make sure that we just monitor them closely for acute kidney injury, because oftentimes these are elderly individuals who also are at high risk just from aging and having then on top of it possible dehydration. Elevated AST, ALT, liver enzymes, looking at those at baseline and then at a routine interval to make sure there's been no changes. You may have some mild elevations. Over time, we really expect hopefully those numbers to improve, but if you saw any numbers concerning for like severely elevated, it would be a referral or tell them to go to their PCP or assess for like an ultrasound of the liver. Thyroid disease, definitely not an absolute contraindication, but if you see a very wildly abnormal TSH, or they have a history of MTC or MEN2, obviously, which is the familial medullary thyroid cancer, they would not be able to start until they got cleared. And it's absolute contraindication for the history of MTC. For patients who have a high A1C, who maybe never had treatment before, who haven't ever had a diagnosis of diabetes, it depends on if they're coming to you already on insulin or sulfonylureas. We want to make sure we don't cause hypoglycemia. So just making sure they have the appropriate specialist monitoring as well. We'll talk a little bit about protein maintenance on another slide, so I'm going to leave that there. Okay, titration science. This is where it gets sticky, right? So patients usually want to escalate, 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 or you have the other set who is very afraid of having side effects and is too scared and wants to stay on the lowest dose. So there's a happy balance somehow. My goal is for patients to lose about 0.5 to 1% a week. I don't want anybody really losing more than 6% in a month. It just increases the risk of potential adverse side effects, gallbladder, pancreatitis, all of that. So patients really need to have this set out at the beginning so that they're aware of what is normal. Some months you may lose maybe a little bit more than 6%. It doesn't mean that that's bad. It's just we don't want that being a pattern. If they're losing, though, less than 0.5%, they can stay at that dose and keep them on that. That's a pretty good rate. However, if insurance is paying for the medicine and they're losing less than 0.5%, or it's drifting down to less than 0.25 per week, I've had patients where the insurance company will deny and stop paying for it. They want to see a specific amount of weight loss. But basically the first month, making sure that they're stable. If they're tolerating that starting dose, I would like them to escalate to the next step without significant GI complaints. As long as things are tolerable, we can increase, and the body weight, rate of body loss, weight loss is safe. Hold and maintaining doses. If they just recently stopped having nausea and stopped the antiemetic, I'd like to see a couple weeks usually before I go up on a dose. If the labs have come back, or if there's any other sort of side effect that you're worried about and need to work up, keep the dose. You can always increase at when those come back. Decreasing doses. Patients are never very happy about this, but if you see that there's a rapid weight loss, and I wouldn't just base it on 1 week, sometimes that can be it can just be one point in time. Really doing a calculation to figure out the last 4 weeks of weight loss. And that way you can really have a good baseline to know what is the true percentage. If they're losing more than 6%, if it's 10%, they should probably step down a dose, depending on what their dose is. Obviously, if they're at the lowest dose, you would continue or consider even just skipping a week. It doesn't happen often. Once patients begin to reach a closer BMI of like 24, 25, I start to evaluate for the plan as we come near maintenance. And I'm going to talk about that briefly in a little bit. But obviously, if they're having intractable GI side effects, I had one patient who it was really complicated. He would tell me he was eating everything correctly, he's working out correctly, all his numbers look good, he wasn't losing too quickly. Every Sunday, he would call and complain that he had nausea and severe vomiting. And this was the day of his injection. And then this would last for 3 days. And then the same thing happened every single week. And he swore he was not doing anything different with his diet. One day I talked to him and I found out actually he admitted that Sundays were his cheat day and he was eating a giant T-bone steak with all the fixings and drinking 3 glasses of wine and it basically just eating like he had the appetite of, a 20-year-old not on GLP-1. And he was sending himself basically into, I think, so much side effects because of what he was taking in. So we found that he finally admitted this. And then he also told me that was the day he was giving his injection. So it was coinciding with sometimes a dose increase, and he was doing all of this. You can only do so much. You can only make the suggestions. And if people keep doing it, they're going to keep having side effects. And at one point I told him I didn't feel comfortable escalating his dose because he kept doing the same thing. At some point, he finally, I guess, gave up and decided he really couldn't eat that way. He was just decided to tell us that he wasn't having side effects anymore. But in those cases, you will have patients who are challenging. And it's really striking this balance of holding the safety line for you and your practice and for their safety. But also we want them to have success and we want them to be getting what they have for goals out of the program, right? This is the art. It's not easy. And some people make it more difficult than others. But plateaus are can be very disruptive to patients. I think people are very sensitive to the idea that they're not responding. There's always this concern about whether you're a non-responder. As you're losing weight, your body becomes adjusted and adapts metabolically to this, meaning now the weight loss is tapering off. And at about 12 to 16 weeks after starting a GLP-1, it's very common for people to have some sort of a plateau. And, as you're going through the weight loss journey, there'll definitely be ups and downs. I don't get too worried if somebody's just had less in 1 month, right? And then usually they'll catch up. If for some reason you truly see that a patient has lost less than 5% at 12 to 16 weeks, that's a low amount at 4 months. At 4 months, they should really be on the maximum dose, hopefully, if they haven't had side effects, or at least working their way up. I will not ever tell somebody that they are a non-responder until they have achieved maximum dose and are tolerating it. And then I'd like to try some other things before we just say it's not working. Switching back and forth and just giving up, halfway through, I'm not a fan of that. I think it's best if you can try all the way up to the max dose. And then if truly you're seeing that this person doesn't respond to semaglutide, but when we've switched them to tirzepatide, they do great, wonderful. But just going back and forth is not perfect. It's better to see what the results are and actually get them to that highest dose. Also looking at other reasons for it, right? Why are they having a slowdown? Is it creeping calories? Is their appetite increasing? Do we need to increase the dose? Tracking the food intake for a couple weeks. Are they constipated? Is that adding extra pounds on the scale, masking weight loss? Has their protein intake dropped? Are they not doing resistance training? Maybe check an in-body. You can see where they are now versus 3 months ago. Are they walking? How's their stress levels, sleep? Looking at their vital signs. Check labs again if you need to. Systemic stress, as we know, and sleep scores are so important and really impact success for patients. So, plateaus are an expected part of the journey. Lower body weight, metabolic adaptations, changes in how much ghrelin and leptin, and external factors like did they start eating snacks again? Are they having the food noise return? Doing a full assessment to understand that is really the only way to break through a plateau. Also, sometimes it's necessary to actually drop down a dose, give the body a little break, and then go back up. I've had that happen where that actually works well for patients who have maybe been on the highest dose of tirzepatide for some time, are tolerating it, and are just hitting a wall. Aside from that, the other strategy is to talk about adding adjunct therapy in addition to the GLP-1. Obviously, taking into account patients' medicine list, looking at metformin, if there's some level of insulin resistance or PCOS, checking labs is always important. Naltrexone and bupropion can be helpful too, obviously looking for interactions. Ruling out other sources of weight gain. Have they been put on any other medicines by any other doctors? Thyroid checking, labs, etc. So the discontinuation data really shows that basically patients will unfortunately likely regain their weight if they stop. Stopping therapy is not usually something I recommend. If you're actually switching, yes. If patients think that they can stop, there needs to be, or they want to stop, they say for cost reasons, etc., they have to stop. I really want to work with them to make sure we get them as close to maintenance as possible, and then put a plan in place that helps them to control this as best as they can without the GLP-1 medication, continuing on some of the others. About 10 to 15% of the population are actually true non-responders. And an interesting study done by Stanford just recently identified that about 10% of people who are diabetic, type 2 diabetics, have a genetic resistance to GLP-1s, which obviously reduces the effectiveness. There's different medicines, I think, on the horizon that are actually targeting those people who are genetically resistant. So it's always something to consider in your practice. Let's see. The other thing I'd like to talk about back on this is on the stall is how high is their BMI? The goal and the journey are going to be completely different for a patient who has a BMI of 50, 45 or 50 versus a patient with a BMI of 31. Likely that patient with a high BMI is not going to have their goal weight reached with GLP-1 therapy alone. It's just probably not possible. Getting them to the point that they can see a bariatric surgeon or discuss that as, and also like part of the therapy is really important, as is just framing the perspective to make sure that they don't have unrealistic expectations. Okay. And so this is sort of my flow chart of how I work with patients. And I feel like this kind of is a flow that, even though it has weeks and phases on it, it's continuous. You're going to be doing this all throughout your weight loss program with your patients, making sure reassessing is usually the most crucial way to spot trends, to find things that you might not have seen without asking the question. Making sure that you're not missing side effects that people are just not telling you about. Keeping an eye on mental health, ensuring all the right diet, resistance training, checking to see how they're feeling at about 16 weeks, where that adaptation phase can really start kicking in. Are they feeling food noise? Are they hearing, like this, having that sensation of increased hunger again? Looking for plateaus, and sort of continuously having high touch points with your patients to make sure that they have their questions answered. Sometimes they may not know to ask a question. Sometimes they may not know if something they are experiencing is expected or not. And oftentimes they'll just not tell you. Let's see. So clinical questions. Some of these are just have come up in my practice commonly, how to navigate them. And these are just a small amount. So if you guys have any questions at the end, please let me know. Patients coming in on insulin or other diabetic medication, it's really important to make sure that you're discussing this if they have an endocrinologist or PCP. I hesitate to do this in telehealth just because it's really hard to manage it closely enough. And typically their endocrinologist or PCP will be doing this in person, but they will obviously have to reduce their insulin dosing. The risk of hypoglycemia is high. You have to sort of balance out the transition off some of the other medicines if needed, based upon what their blood sugar levels are, their A1C, et cetera. So it really does require a specialist to be also assisting in that. Transitioning patients from compounded medicines to prescription or vice versa. Compounded agent transition is very dependent upon what is your concentration, what are the other products added in. There's really no head-to-head comparison. I was talking to Dr. Kaplan about this earlier. You can establish that in your practice with the pharmacy that you're obtaining the compounded medications from. But as far as from compounded to prescription, even if the patient was on the highest dose of a compounded medicine, I like to keep them on the lowest dose of the prescription. The reason is you just don't know how they'll react to the different molecule. It's not going to be exactly the same. They may tolerate it well, they may not. If it's been somebody that's been on maintenance for a very long time, say they have a max dose of semaglutide and it's been a couple years, I would feel more comfortable about maybe putting them on like a second step of prescription, Zepbound. But again, we want to make sure that you're not starting too high. It's always easier to titrate up than to take it back. Patients who request 3-month supplies of medication during the active titration. I don't advise this. I think for a lot of reasons. If it's compounded medicine, there are different challenges, but you can't easily titrate if the patient has the dose on hand. I find that this leads to medication errors. I've had patients double dose, triple dose, quadruple dose because they just decided not to look at the syringe. Crazy things happen. But I feel like giving them a huge supply is a setup for potential disaster. Obviously, if people are traveling or going on holidays, giving them what they need is great, but to just continually do that while they're actively losing weight is not safe. Oral contraception. And in general, pregnancy risk on especially tirzepatide. Obviously, there is that potential we have to warn patients about that they could become pregnant. Again, these medicines are amazing. They're helping people have return to fertility who have been dealing with PCOS. I've had probably a handful of patients get pregnant on GLP-1s. And obviously, it's always concerning because they're like, oh no, have I done something wrong? Well, obviously, we want you to stop right away. If you find out that your patient's pregnant, have them stop, have them follow up with OB. But when they initiate therapy, they really should be having a backup method to prevent pregnancy. Phentermine and GLP-1s, not standard protocol, do not recommend it. Phentermine is meant for short-term use to help with appetite suppression. GLP-1 therapy should be providing sufficient appetite suppression. Sometimes patients will take longer than others at the beginning to feel the full effects. They may be annoyed in the first month that it's magically not taking away all of their hunger. You have to let them know that it does take time and that we have to work our way up. I would not add anything, and especially not phentermine, but I would not add anything to the GLP-1 until you actually get to a maintenance dose and you're seeing that they're not responsive. And then special circumstances, undergoing surgical procedure, having an operation while in a GLP-1, defer to obviously the anesthesiologist or surgeon, but typically the minimum amount is 7 days prior that they would want to take the last dose because there is that risk of aspiration. So, practice pillars. Obesity is a chronic disease that doesn't end when we write the prescription. The journey begins with a medicine. Think of that as, how the gateway to success, right? The clinical protocols that we put in place and the care that the providers give the patients and the guidance are really the keys to success. So structured titration, high touch engagement, proactive side effect management, and expectation setting day one, even if it's a difficult conversation. Making sure the protocols prevent rapid escalation, reducing the risk of adverse events, and building patients' confidence in your program. High-touch engagement, making sure that they have a plan in place, whether or not it's a telehealth or in-person clinic, and really making sure that they feel comfortable reaching out in that first couple months with any potential side effects or questions. And again, prevention is, I think, the most important thing is regarding side effects. Anticipate issues, have a plan in place before they become a crisis. And then discussing with the patient the plateaus, weight velocity, what success really looks like, and why this is a chronic long-term management protocol, not a quick fix. As much as we want everybody to fit into that dress in a month for their best friend's wedding, it's not always possible. We have to set those expectations. So let's see. Any other questions? Thank you.
All right, there is one. So, patients that are plateauing, is there a benefit to adding any specific peptides?
So, that is a whole other conversation outside of this. I feel like there definitely can be, given that, legally prescribing peptides is still not there yet. Things like MOTS-C and others can also be beneficial, but I think this is sort of another conversation we would have to have about the safety approach there, since they are research peptides and they can not only be turning on keys that are good in our body, they can also put higher risk for other conditions. So case by case basis, I think it's most important to really get up to the max dose to do all of the assessments I mentioned, and then to try to add on some of the prescription adjuncts to see if that helps. And, like between metformin and bupropion, naltrexone, they have anywhere from like 3 to 6% annual weight loss, which alone isn't much, but if they're having a little point where they're stuck, could be beneficial to help getting them over that.
And then thoughts on oral versus injectable GLP-1s?
Yeah, well, I mean, look, the oral semaglutide is now available in a higher dose. I know there are ones coming out on the market that are going to probably even be better than that. I think it is an amazing option for patients who, maybe it's a financial situation or they just don't want to do injections. I think there are limitations, but I think depending on the patient's situation, it could be a wonderful option.
That's great. You mentioned the course, so you're
Yes.
going to be launching a course with so many more details, which we will be sharing out. And then also we have our our mastermind monthly sessions,
Yes.
which you are now going to be helping us
Yes.
lead,
And
which is exciting.
yes, and also working on for everybody that joins the course, I will actually have a SOP guideline book that has all of this information and more, and really structured, like, transitioning from one med to another, contraindications. We go over all the labs, everything, and this can then be tailored to your practice with your information and be put into place as a framework. This is it's an art at the end of the day. Everybody's different. We all have different management styles of clinical situations, and really finding out how to use the tools and help your patients is where the individuality comes in.
Yeah, I'm very excited for that
Yeah.
that launch. And then yes, we will actually we have one presentation left, which I am up for. And we'll actually talk a little bit more about the mastermind sessions, which we're going to start getting kicked off. So with that, thank you so
Okay,
much
thank
for being
you.
here.